This episode is sponsored by Simple Practice.
Running a private practice is rewarding, but it can also be demanding. Simple Practice changes all that. This practice management solution helps you focus on what's most important, your clients, by simplifying the business side of private practice like billing and scheduling.
Stick around for a special offer at the end of this episode.
This podcast is also sponsored by Private Practice Grief.
What if you knew exactly what to say when a client went through a death, a divorce, or the loss of a pet? What if you could give them a true, meaningful experience and never feel nervous or overwhelmed in the face of grief again? What if you had an expansive toolbox of resources and ways to help your clients navigate through their pain? What if you had a solid framework to guide you? Private Practice Grief Trainings helps you as clinicians and therapists to confidently address the devastating effects of grief so your clients can find hope and joy again.
Listen at the end of the episode for a special offer.
You're listening to the Modern Therapist Survival Guide, where therapists live, breathe, and practice as human beings. To support you as a whole person and a therapist, here are your hosts, Curt Widhalm and Katie Vernoy.
Welcome back, Modern Therapists. This is the Modern Therapist Survival Guide. I'm Curt Widhalm with Katie Vernoy. We are days away from Therapy Reimagine 2020. Last week, we talked about my topic that's coming up for the Therapy Reimagine virtual conference. This week, we're going to dive into Katie's talk and give you a little bit of a preview of what she's bringing out. There is still time to get your tickets for the live event. Go to therapyreimagineconference.com to get those. And in the meantime, listen to Katie.
Oh, I thank you. So where we ended last week was kind of interesting because it does lead into what we're talking about today and what I'll be talking about in the conference, which is the case for self-care. I think my talk is called Showing Up, the therapist effects on clinical outcomes or something like that. And it's really making the case for continuing education. And in your plea last week, also ethical codes that talk about how therapists take care of themselves, how they pay attention to themselves, because I think oftentimes in an effort to protect clients or consumers, we are listening to consumer protection bodies and not necessarily to the research. And so when we look at, and I don't know if you, because you've done a lot of RCE stuff, if you have the specific language, but I've been told repeatedly, self-care talks are not CE worthy. You should not talk about self-care. It has to be client-facing. And I get that. Like if we just use our continuing education to get massages, like, yes, that is BS. Like we shouldn't be doing that, even though I think that potentially there's an argument for massages as a business expense. But that is a whole other conversation.
Right.
But it's not continuing education though, right? Like I do believe that the continuing education should make us better therapists and better able to show up for our clients. However, I think there are some theoretical problems with how that is currently viewed by our consumer protection bodies and CE bodies because of the medical model. Because the medical model says that we are, I think we, in Harry's conversation on the podcast, talked about kind of surgeons performing interventions, those types of things. It's very focused on what we do to clients and not how we are with clients and who we are when we're with our clients.
My understanding from the governing bodies of continuing education on that point is the specificity of where continuing education needs to be needs to have demonstrable effects on client outcomes. And that if we focus too much on, clinicians taking care of themselves, going to the spa, this kind of stuff, yeah, I've been around enough CE things that I see where that particular area is rife for abuse. But it does ignore what we've talked about here on the podcast as far as showing up for your clients. Weird how that's the name of your conversation.
Well, I named it that because I believe that is our goal, is to show up well for our clients. I think oftentimes, and I talk about this with sacrificial helping or in all the self-care stuff that I talk about, in the burnout stuff that I do, is that we want to help people. We want to give of ourselves. And so I want to honor that. That's where we're starting from. But when we sacrifice ourselves in that effort, we actually are not showing up as well as we could. And so I think when our protection body says focus on the client, when our instincts and our desires say focus on the client, I think we do need, so I agree with your last point from last week about ethics. I do think we need to have some sort of guidance saying there needs to be a focus on the clinician to the betterment of the profession and the work. Because if we just said clinicians just have to have a great life, like, sure, I think we do, but I don't think that that's what our consumer protection bodies are going to necessarily go for.
And many consumer protection bodies are going to say that's their responsibilities to protect the consumers, and you as therapists are out there, you're not consumers until you're going to get your own therapy or whatever, but that their job is to protect the consumer and to overregulate therapists in whatever it is that they do, especially on kind of the personal end of things, is potentially not their lane.
I think that some of the regulations or the ethical codes do speak to kind of the idea I'm thinking was kind of broken tools, right? Like if you are truly incompetent and you're doing things that are truly harmful to clients, they are going to regulate that. But as far as seeking excellence and having clinicians be, and I hate to call clinician tools, that just sounds bad, but having clinicians be as strong in giving the work, giving the clinical guidance and the support to our clients as we can, they're silent on that part. And I think that does actually impact consumers quite a lot. In fact, when we look at kind of the medical model, which is where a lot of the research has been in the past, and where we get the idea that the specific type of treatment that we do makes a difference, there is kind of a mechanism in which we test it that really suggests that if we do it, if every clinician is all the same and we do this type of treatment all the same, then we will get a consistent result. And that's not what the research has shown. And not even when they try to deconstruct a certain methodologies, they take out a piece of a clinical orientation or treatment modality, do they get different things? So like, even if you take out part of CBT and you give CBT, you can't tell the difference in the results. So even adherence is not showing up on a regular basis as saying like, hey, the treatment we provide, if we just look at the treatment model, actually makes a difference. And so in regulating that and not how we show up as clinicians on a more positive way, allowing us for our own development in a way that actually supports us as individuals, I think it misses the mark.
It sounds like what you're speaking to is aiming models and aiming ethics, what we talked about last week, is towards the least common denominator of our profession. And I've heard this in discussions from licensing board language of that licenses serve as the minimally acceptable amount of competence that a clinician can have to practice independently. But you're speaking beyond minimal competence and into expertise.
You're right. I think that this is, again, kind of we're looking at an aspirational, how do we make clinicians better versus how do we regulate against the least common denominator. I think it just is too simplistic to talk about just treatment being provided versus how clinicians show up. And I don't know that I can explain it better than that, but I do think that when we look at the differences between humans providing treatment and knowing that there's differences in clinicians versus some sort of computer or surgeon doing some sort of a consistent mechanism of treatment, I think we lose some translation if we don't in some way address the individual in the room.
Partially, in what I'm kind of going in my imagination to on this is, if our jobs ever get replaced by AI and by computers, and I choose the word jobs here very specifically, then it makes what we're doing jobs. It doesn't have that professional aspect to it. And it's that professionality that emphasizes that we should be doing the best that we can, that we should be aiming beyond the minimal acceptable competence, that we should be more than just kind of coming in and punching the time clock and working the day.
Yeah. And I think it It's seen, and I don't remember which article this was from, but for folks who see therapy as an art versus just a science, they're actually better. They're seen by their clients as being better clinicians. I think it's a perfect. I'll find the article and I'll put it in the show notes along with the other stuff I'll be talking about today. But when we look at it as an art and a relationship, or as Dr. Harry Ponte talks about, an experience, I think that there are hints and even specific bold signs on how we actually need to make sure that we're showing up. And there's actually data that supports that taking care of clinicians makes a lot of sense for the efficacy of the work. In Bruce Wampold's work, and he did a couple of things in 2015. There's an article that I'll link to in the show notes, as well as the book, The Great Psychotherapy Debate. He actually takes up the argument and pits the medical model against this model that really focuses on what are called non-specific effects. So these are potentially therapist effects. They are potentially things that are differences about clients, things that are happening in the relationship that are separate from or kind of happening at the same time as any specific treatment that someone is providing. So for example, you as a clinician, your client as a client, the relationship between the two of you while you're performing the specific treatment of EMDR. So it's only looking at you, your client, and the relationship. And that could happen across any of the modalities. And so they're called common factors. And he actually further defined it and called it the contextual model. So it's looking at the context within which you're doing a specific type of treatment. And so when he was looking at that and doing, there's a lot of meta-analysis that goes into it, and he makes a very long defense for why that's the best way to do this. But in looking at that and really identifying what makes a difference, the contextual model says that there's the initial relationship, the bond that's developed, and that's required. So you can't go beyond that. So you have to create a bond before therapy can really start. And then you start developing the real relationship over time. And that's the first pathway to therapeutic change. Then there's kind of the expectations that the client has. And this is where you get into, the therapeutic alliance and the agreements on what therapy is. And then beyond that, so the third pathway to success are the specific ingredients, which is the type of treatment like EMDR. And so when we're looking at that, the relationship, or the initial bond, I guess, the initial therapeutic relationship, the real relationship, and then the expectations that are set within that relationship, all are about everything but what actual treatment you're providing, which so much of, I think, our continuing education is, here is how we do this modality. Now, not our conference, so please come and we're going to talk about all these other things. But even when Wampold talks about specific ingredients, he's talking about, it's not even how adherent you are to them or how well it's aligned to a specific diagnosis. It's that there are specific ingredients, that the client understands them and agrees that that's the best modality for treatment. So it's all very relational. It's all based on the conversations that you have with your client to talk about, why are we doing this? How am I showing up? Do you agree with this? And we're on the same page. And so it's about being in relationship to cause clients to do things that improve their health and well-being.
I'm a huge Wampold fan, and for longtime listeners of the podcast know that this all tends to make sense based on the broader context of the conversations that Katie and I have. That, all right, you as a human impact therapy, and you can be better at being a human that shows up for therapy is where I assume that you're going with this.
Yes.
So part of this then seems to be, how do we practice at being better humans?
Well, I think the first thing that I really come to is that we actually have to have lives outside of our work. Because if we are just therapists sitting in rooms talking to clients all the time, or on screens, or walking and talking, or in somebody's home, whatever it is, if we are just spending so many hours of our week, so many weeks of our year so many years of our lives just being therapists without living our lives, I think it's very hard to show up as a human being in the room. You're experiencing the world vicariously. And I know for myself, I did a little bit of that at the beginning of the pandemic. I was hearing news from clients versus being out exploring the news myself, like doing stuff. Like, yeah, I got some news, but it was all based on whichever client came into my simple practice treatment office, video office during the day. I mean, like there were literally times when a client was informing me of some atrocity that had occurred, and I'm responding in real time. That was not my best moment, and I honored that. Like, I needed to take some more time to myself so that I could actually have my own understanding of what was happening, that I could be living life in the way that humans are living life right now, so that I had a frame of reference. Mm-hmm. And so part of being a better human is having space to be a human and not just button seat hours.
As you're describing it, it's having, again, the word context. I can't really think of a better word here, but it's having the context to be able to demonstrate vulnerability. It's being able to model for clients, being able to show them and one of the things that I'm coming up against, Harry talks about it being a surgeon, but even before Harry was around, Gabrielle Marcel was talking about that if we remove all of the humanity out of therapy, therapists are no better than being a pen. That it's just, kind of talking in the context of, it's just, if you're there, if you don't have any of this kind of stuff, even in the nature of the pandemic, it's the clients wanting to know how you're responding to the world.
Yeah.
Permission themselves to be able to respond to the world.
Yeah.
And so I think, I mean, we wouldn't be together this long in our ventures if we didn't agree on this stuff. So
yeah. So you agree.
Totally.
Well, and I think the other thing, and this speaks more to probably what I'm going to be addressing in the talk at the conference, is that we also need to make sure that we're showing up professionally in a revitalized, resourced way. And I think oftentimes, and we've talked about this a number of times, we can link to some of those episodes in the show notes, but like burnout becomes a big risk for us in our careers, and like, oh, that's going to hurt the therapist, and oh no, that's going to be a problem. But when we look at a study as recently, there was another meta-analysis by Zimmerman and some colleagues in 2016, and I'll put that in the show notes. And there was a lot of different studies that they cited, so I can't list all of those. But when we look at outcomes on that are really negative, so if we look at dropping out of treatment, not getting good therapeutic results in treatment, if I'm going to read these things and just start thinking in your mind, how many of these are present when you're burned out? So we've got lack of empathy, negative countertransference,
totally,
overuse of transference interpretations, disagreement with the therapist or the client about the therapy process. So between the therapist and the client, you're disagreeing what should be happening in therapy.
Sure.
So all of those, to me, like, it's like, oh, okay, well, we can look at those in isolation. Those are things that are just bad. Don't do them. But I know when I'm most burned out, I don't like people. And I see everything that they do as negatively impacting me. I see them as defensive. It's their problem, not mine. Like, if we look at this, if we aren't actually able to keep ourselves from burnout, and not just manage it, but keep ourselves from burnout, our clients are going to drop out of treatment.
Which reflects poorly on us as individual practitioners. Mm-hmm. It reflects poorly on psychotherapy as a field.
Yeah.
That, hey, in this Yahoo over here, I went to a couple of sessions. They didn't respond well to me. All therapy is a joke.
Yes. Yeah. And so I think it's super important for us to be able to do that. There's also a study that by Landrum, Knight, and Flynn from 2012 that says if we're burned out, organizational stress and burnout, if we're burned out, our clients are not going to engage. So even if they don't drop out, if they're not engaged, and they don't really see it as that valuable, they're not going to be, well, certainly on the business side, they're not going to be referring their friends, but they're also going to have, like what you just said, they're going to have this negative perception of therapy, even if it's just that they're kind of meh on it. Mm. So another element that I think is really important, and that the question that you asked, how do we show up as better humans? The question I think really also goes to, how do we have better relationships? Because I think in our human life, I think we're a socialized society. We want social interactions. We want social connections, and people do it differently. So I'm not saying there's a right way to do it, but when we look at, and we've cited this study before, but Betty and Duff from 2014, they talk about what's most important for clients as far as a therapeutic alliance. And we talked about this in a previous episode. I'll leave it there that we'll check that out in the show notes. But so many of the things that it talks about, therapist honesty, making eye contact, the body language that we have, clients feeling heard and respected, validating the client's experience, showing good boundaries. These are also the things that I think get very harmed when therapists are burned out and they're not. And we're not trained on how to set up our schedules. We're not trained on how to make sure that our environments are conducive for our work. We're not trained on how best to optimize our mental performance, because this is deep mental work that we're doing as clinicians.
I think it's that we are in such a rush to get to the doing of therapy. And Katie and I crap on graduate education and continuing education, pretty frequently here, but we're in such a rush to get to the specifics of techniques within our major study of field that we often fail to incorporate the other general knowledge that comes from human behavioral health. We pull from flow psychology in our
systems of self-care.
In our systems of self-care talk. And that's not necessarily something that's specifically taught as a therapeutic technique, but very much from the field of positive psychology, that depending on the nature of the people choosing the curriculum, ends up getting pushed to the side and underemphasized when it's something that could benefit us. Now, what you are speaking to, though, is it takes an incredible amount of resources, time, money, otherwise, the effort that goes into putting yourself into this place in order to be able to do it.
What do you mean?
That if a graduate program is 60 units, 70 units, 80 units long, and, paging Dr. Caldwell and saving psychotherapy here, that there's no evidence that longer graduate programs actually turn out better therapists, but you have this really confined amount of classroom time to cover what is an ever-expanding list of things that we quote-unquote all therapists should know, that limits what can be presented, and those things that do take those time and effort resources end up kind of getting pushed to the wayside in order to fit in all the other stuff.
Well, I think that speaks again to our licensing boards and our consumer protection bodies. I think the things that are chosen to be put into those curriculums are based on the medical model. And so you have to learn all of these theories regardless of whether or not they're relevant and whether or not they make a difference. There's a requirement to learn about specific populations, which I think can be very helpful, but oftentimes they're reductionistic, and they don't actually give you enough information except to know that what you don't know, which has a benefit. I agree that's important, but I also think that, a checkbox of I've learned about X means that I now know how to serve those clients is also problematic. And so, yes, there's not a lot of time in our grad programs, and we've already put way too many units in them, but we're just adding and shifting. We're not actually reimagining education to say, what do people actually need to be good therapists? Like, what needs to happen for someone to do really good therapeutic work with their clients? Because at this point, and this is in 2015, and I think initially it was in 2001, Wampold was saying the research is showing that the medical model is disintegrating.
Mm-hmm.
So to continue to design education based on a model that is disintegrating, that the medical model actually, at least according to Wampold's impression of it in the 2015 book I'm referencing, is that cultural factors are irrelevant. If a treatment model is done properly, it goes beyond that.
Mm-hmm.
I mean, that's ridiculous. That is completely ridiculous.
So within this, I came across this article from Ariel Nobel and Rosemary Risk, and it's called "It's Led Me Astray: How Cognitive Behavioral Therapists Experience Personal Therapy in Clinical Practice." Now, this is a really small study. This is 7 very hardcore CBT therapists who are exposed to personal therapy. And this article goes on and explains that a lot of therapists love getting psychotherapy. They feel that it adds to themselves as a person and as a professional practitioner. However, all 7 of these therapists that were studied after going through a number of personal psychotherapy sessions from a non-CBT model ended up reporting that having more self-awareness impacted their work of being able to do CBT. In other words, it's so much removing the humanity out of this that makes it to where the model ends up having to work. Now, I have to guess that there's a lot of us who do CBT, and then there's those who do CBT.
Yes.
And this is maybe potentially studying those more out in the latter group there. But I think in really having kind of that separation from something makes therapy feel cold. And I think in a lot of the research that you're citing here, it backs it up.
Yeah, for sure. And I think when we look at that, I think that it is so much easier. And I feel like I'm on repeat here from a lot of the things we've already said, but there is so much that suggests studying things within a medical model is easier, it's cleaner, but it truly does take out the humanity. And I think we can't remove humanity from the therapeutic process. Like, it's just impossible. And when I look at kind of the differences that are seen that the contextual model says are therapist effects, and the medical model is just like, oh, well, the clinician wasn't competent enough, or they weren't compliant enough, or they weren't adherent enough. Even if that's true, those are therapist effects too.
Right.
And so we can't get that clean ivory tower, everybody does the treatment exactly the same, unless we go to this idea that we were kind of, speaking about earlier, is this AI doing these interventions. And I guess maybe that's the study, is that you have AIs doing some sort of adherent model or not adherent, or all those things, that you take out the humanity completely and see if there are actual differences. But that's only relevant if we have no differences between therapists. If what we bring into the room as individual human beings makes no difference. And that seems, I'm going to say the word again, ridiculous.
It seems like the Matrix. Like you just need to grow these little human pods that you keep locked away somewhere.
Yeah.
And turn them out to be the therapists of the future.
Yes. And so to kind of speak to how I view the world, as well as what I'm going to be talking about at the conference later this week, who we are makes a difference. What we do in the room makes a difference. Not necessarily the interventions that we apply, but how we show up. And when we think about how to show up and do the best work that we can, we have to include these ideas of structuring our work and taking care of ourselves. And those are things that are really not taught. And oftentimes those things are frowned upon by continuing education bodies. But don't worry, I did take care of it. I got it covered. So we're going to have that for CE. But just knowing that I think this is an area that we push back, whether it's like Curt was talking about last week, putting something in our ethical codes, or if it's really making lots of appeals to our continuing education bodies saying, we need to know how to be therapists. We need to know how to set up our practices so that we can show up for our clients. And that includes self-care business practices. It includes making time for ourselves so that we have the mental bandwidth to be able to be focused on our clients. Because if we are just seen as robots doing interventions, and that's all that needs to be regulated are the interventions that we do, it's really short-sighted and it harms our clients.
You can still get your tickets with us. You can get those at therapyreimagineconference.com. Coming up this Thursday, Friday, Saturday, wherever you are in the world, it's available to you.
We have a really cool app. It's so cool. You get to sign in and meet all your friends. It's going to be great.
We are really trying to make this as much of a virtual conference experience that's as close as we can make it to a in-person conference experience. Lots of between session networking time, ability to connect with everybody else. And, I'm missing going out to conferences and some of the social aspect, and really trying to make sure that this doesn't just feel like you're sitting and doing webinars like maybe some of the other conferences are doing. And so we would love to have you join us. We have people from all over the country, all over the world, and look forward to having you. So thank you for being a modern therapist. And until next time, I'm Curt Widhalm with Katie Vernoy.
Thanks again to our sponsor, Simple Practice.
Simple Practice is the leading EHR platform for private practitioners everywhere. More than 60,000 professionals use Simple Practice to power telehealth sessions, schedule appointments, file insurance claims, communicate with clients, and so much more, all in one HIPAA-compliant platform. Get your first 2 months of Simple Practice for the price of one when you sign up for an account today. This exclusive offer is valid for new customers only.
Go to simplepractice.com/therapy reimagine to learn more.
Also, thanks to our sponsor, Private Practice Grief.
Debbie Jenkins-Frankel is the force behind Private Practice Grief trainings, and she is passionate about helping you transform yourself as a clinician. Grief comes in our offices every day, and once you recognize it and know how to handle it, you'll be able to expand your practice so we can heal the world. Advanced grief training therapy for only $395. Want to feel more confident to address grief with your clients? Want to find out how to help them with feelings of guilt and remorse? You need more training, strategies, and resources in specific areas of grief. Join Private Practice Grief Trainings for a 6-week comprehensive advanced online training, which includes 20 CEs for LMFTs, LCSWs, and LPCCs in California. $300 off the regular price of $695 with your attendee code for registrants of the Therapy Reimagine 2020 conference.
Check out our other courses and consultation available at privatepracticegrief.com.
Thank you for listening to the Modern Therapist Survival Guide. Learn more about who we are and what we do at mtsgpodcast.com. You can also join us on Facebook and Twitter. And please don't forget to subscribe so you don't miss any of our episodes.